Dear listeners, this is the beginning of part 3 in this 4-part series on ischemic heart disease. For other videos in this series, see Prescribon Medical Education series, Ischemic Heart Disease. Patterns of infarction. The distribution of myocardial necrosis correlates with the location and cause of the decreased perfusion. Knowledge of the areas of myocardium perfused by the major coronary arteries allows correlation of specific vascular obstructions with their corresponding areas of myocardial infarction. Typically, the left anterior descending branch of the left coronary artery supplies most of the apex of the heart, the anterior, that is front wall of the left ventricle, and the anterior two-thirds of the ventricular septum. By convention, the coronary artery, either right coronary artery RCA or left circumflex artery LCX, that perfuses the posterior third of the septum is called dominant, even though the LAD and LCX collectively perfuse the majority of the left ventricular myocardium. In a right dominant circulation, present in approximately 80% of individuals, the right coronary artery supplies the entire right ventricular free wall, the posterobasal wall of the left ventricle, and the posterior third of the ventricular septum. The left circumflex artery generally perfuses only the lateral wall of the left ventricle. Thus, right coronary artery occlusions can potentially lead to left ventricular damage. Although most hearts have numerous intercoronary anastomosis, that is collateral circulation, relatively little blood normally courses through these. However, when a coronary artery is progressively narrowed over time, blood flows via the collaterals from the high to the low pressure circulation, causing the channels to enlarge. Through such progressive dilation and growth of collaterals stimulated by ischemia, blood flow is provided to areas of myocardium that would otherwise be deprived of adequate perfusion. Dear listeners, by the way, this educational video is made possible by Prescribon, the makers of e-prescription software for digital prescriptions, available freely for doctors on the website www.prescribon.com. Doctors who are interested in this e-prescription can freely avail of its vast collection of more than 100,000 e-prescriptions. Transmural infarctions. Transmural infarctions occur when there is occlusion of an epicardial vessel in the absence of any therapeutic intervention. The necrosis involves virtually the full thickness of the ventricular wall in the distribution of the affected coronary. This pattern of infarction is usually associated with a combination of chronic coronary atherosclerosis, acute plaque change, that is hemorrhage within the plaque or rupture of the fibrous cap under the inner lining of the endothelium, and superimposed thrombosis, that is clotting, discussed earlier. Subendocardial, that is non-transmural infarctions. Subendocardial non-transmural infarctions can occur as a result of a plaque disruption followed by a coronary thrombus that becomes lysed spontaneously, that is naturally, or therapeutically, giving medicines before myocardial necrosis extends across the full thickness of the wall. Subendocardial infarcts can also result from prolonged severe reduction in systemic blood pressure, as in shock, superimposed on chronic, otherwise non-critical coronary stenosis. In the subendothelial infarcts that occur as a result of global, that is general hypotension, myocardial damage is often circumferential rather than being limited to the distribution of a single major coronary artery. Multifocal microinfarction. Multifocal microinfarction refers to a pattern that is seen when there is pathology involving only smaller intramural vessels. This figure shows the coronary artery circulation of the heart. Right coronary artery and the right marginal artery are shown on the right side. Left coronary artery, left circumflex artery, left marginal artery, and the left anterior descending arteries are also shown. Order of frequency of involvement of coronary arteries. See figure coronary arteries shown earlier. The frequencies of involvement of each of the three main arterial trunks and the corresponding sites of myocardial lesions resulting in infarction are as follows. Left anterior descending coronary artery, 40 to 50% of the cases. Infarcts involving the anterior wall of the left ventricle near the apex, the anterior portion of ventricular septum, and the apex circumferentially. The right coronary artery involved in 30 to 40% of cases. Infarcts involving the inferior or posterior wall of the left ventricle, posterior portion of in ventricular septum, and the inferior or posterior right ventricular free wall in some cases. Left circumflex artery involved in 15 to 20% of cases. Infarcts involving the lateral wall of the left ventricle except at the apex. Less common locations. Other locations of critical coronary arterial lesions causing infarcts are sometimes encountered, such as the left main coronary artery, the secondary, that is diagonal branches of the left anterior descending coronary artery, or the marginal branches of the left circumflex coronary artery. Isolated infarction of the right ventricle is unusual, only 1 to 3% of cases, as is infarction of the atria. Changes in the myocardium after myocardial infarction. Damaged myocardium undergoes a progressive sequence of morphologic changes involving typical ischemic coagulative necrosis, the predominant mechanism of cell death in myocardial infarction, although apoptosis can also occur. This is followed by stereotypical inflammation and repair by fibrosis and formation of scar tissue over a course of around 2 months. Note: coagulative necrosis. An explanation. A type of cell death that occurs when blood flow to cells stops or slows, that is ischemia. The architectures of dead tissue is preserved for at least a couple of days. The necrosis denatures structural proteins and lysosomal, that is digestive enzymes, thus blocking the breakdown of proteins of the damaged cells. The lack of lysosomal enzymes allows it to maintain a coagulated morphology for some time. Early morphologic recognition of acute myocardial infarction can be difficult. However, if the infarct preceded death by at least 2 to 3 hours, it is possible to highlight the area of necrosis by special techniques. By 3 to 7 days, the infarct is rimmed by a zone of highly vascularized granulation tissue. Note: granulation tissue is formed as part of the healing process. It is characterized by the presence and proliferation of fibroblasts, which produce fibrous tissue, endothelial cells, new thin-walled capillaries, and inflammatory cell infiltration of the extracellular matrix. Thereafter, the infarct becomes progressively more sharply defined, yellowish, and has a grey-white scar. Over the succeeding weeks, the injured region evolves to a fibrous scar. Necrotic myocardium elicits acute inflammation, most prominent in 1 to 3 days after myocardial infarction, followed by a wave of macrophages that remove necrotic myocytes, that is about 3 to 7 days after myocardial infarction. The infarcted zone is progressively replaced by granulation tissue 7 to 10 days after myocardial infarction. which in turn forms the provisional scaffolding on which dense collagenous scar forms. Because cardiac myocytes are terminally differentiated cells, no cardiomyocyte proliferation is seen. This fact is very important to remember. In most instances, scarring is well advanced by the end of the 6th week. Healing requires the migration of inflammatory cells and ingrowth of new vessels from the infarct margins. Thus, an MI, that is myocardial infarction, heals from its borders towards the center, and a large infarct may not heal as fast or as completely as a small one. Moreover, malnutrition, poor vasculature, or exogenous anti-inflammatory steroids can impede effective infarct scarring. Changes resulting from interventions that can limit infarct size by salvaging myocardium that is not yet necrotic. Infarct modification by reperfusion. The therapeutic goal in acute MI is to salvage the maximal amount of ischemic myocardium. This is accomplished by restoration of tissue perfusion as quickly as possible. Hence the adage, time is myocardium. Such reperfusion is achieved by thrombolysis, that is dissolution of thrombus by tissue plasminogen activator, angioplasty, or coronary arterial bypass graft (CABG). Unfortunately, although preservation of viable but at-risk heart can improve both short and long-term outcomes, reperfusion is not an unalloyed blessing. Indeed, late restoration of blood flow into ischemic tissues can be associated with arrhythmias and can incite greater local damage than might otherwise have occurred, so-called reperfusion injury. It has been estimated that up to 50% or more of the ultimate infarct size can be attributed to the effects of reperfusion injury. Reperfused myocardium, that is vascular circulation restoration after ischemia or infarct, has occurred in the setting of an acute myocardial infarction is typically hemorrhagic as a consequence of vascular injury and leakiness. Microscopically, irreversibly damaged myocytes after reperfusion develop contraction band necrosis. In this pathologic process, intense eosinophilic bands of hypercontracted sarcomeres are created by an influx of calcium across plasma membranes that heightens actin-myosin interactions. In the absence of adenosine triphosphate ATP, the sarcomeres cannot relax and get stuck in an agonal tetanic state. Thus, although reperfusion can salvage reversibly injured cells, it also alters the morphology of irreversibly injured cells. The biochemical abnormalities and their functional consequences may also persist for days to weeks in reperfused myocytes. Such changes are thought to underlie a phenomenon referred to as stunned myocardium, a state of prolonged contractile dysfunction induced by short-term ischemia that usually recovers after several days. Myocardium that is subjected to chronic sublethal ischemia can also enter into a state of lowered metabolism and function called hibernation. Subsequent revascularization, example by CABG surgery, angioplasty, or stenting, often restores normal function to such hibernating myocardia. Dear listeners, this is the end of part 3 in this 4-part series on ischemic heart disease. For other videos in this series, See Prescribon Medical Education Series, Ischemic Heart Disease.